Okay, it's 12 noon. Hello, everyone. This is Vijahi Batuman. I'm the interim chair for the Deming Department of Medicine. Dr. Josh Danson from our Division of Pulmonary Disease and Critical Care will introduce our guest speaker today. Josh, take over.
Thank you, Dr. Batuman. Hello, everybody. Welcome. First, I'd like to introduce today's speaker. Is Joanna Abraham. She's an assistant professor in the Department of Anesthesiology and at the Institute for Informatics at Washington University School of Medicine in St. Louis. She's an interdisciplinary researcher with training in computer science, biomedical informatics, and human-centered design. Her research program targets the development of collaborative systems to deliver safe and coordinated care. Her research focuses on streamlining clinical workflows in a variety of domains, including handoffs and care transitions, care coordination, clinical decision-making, and medication ordering. And in these domains, our research focuses on the design and evaluation of health information technology for continuous and sustained improvements to patient safety. She's received several awards for her early contributions to the field of medical informatics, including the AMA New Investigator Award, Distinguished Paper Award, and Diana Forsyth Award. She's internationally recognized for her work and funded by several organizations, including AHRQ, and she is a friend and a trusted colleague in this area of research, and I couldn't be more happy to give her the opportunity to present her work for us today. So without further, Dr. Abraham, thank you for joining us.
Thank you. Good afternoon, all. Can you hear me okay? Okay, good afternoon, all. Thank you, Josh, for the kind and wonderful introduction. And thank you to actually inviting me for this grand rounds at your university. It would have been much better if I was in person, but given all the constraints, I think a Zoom works perfectly well. And thank you for this opportunity again. So today's talk, I'm going to focus on my research related to handoffs and the lost art of communication. I guess it's not moving. Okay, doesn't move that way. I have no conflicts of interest to disclose, and I've received funding from multiple organizations, including James S. McDonald Foundation, National Science Foundation, and the Agency for Healthcare Research and Quality for my research on handoffs. Before I get into my research itself, I thought I'll take a few minutes to talk about my training experiences and the backgrounds I come with. So I did my computer science undergrad from a university in India, and which had a heavy focus on both software engineering and hardware engineering. Then I moved on to Penn State for my PhD in information sciences and technology, and the heavy emphasis was on design, human-computer interaction, usability, and evaluation of large healthcare or organizational systems. Following my PhD, I moved to do an ARC-funded postdoctoral fellowship at University of Texas in Houston, and the emphasis there was more on patient safety and health IT. So I used a lot of human factors principles and borrowed some frameworks from human factors to understand the effect of the system at large and its effect on processes and patient outcomes. Finally, the last stop in my training was at New York Academy of Medicine, which had a more focus on public health. And I was actually in the Center for Cognitive Studies and Decision Making. So I got a lot of training in cognitive informatics methods and how it relates to decision making and clinician reasoning in general. So given all these interdisciplinary background and training, I actually situated myself in medical informatics. So if you look at these circles, you'll see I could call myself at the intersection of social sciences and mathematical and computational sciences. My research in biomedical informatics actually falls in four broad research areas, but they're highly interrelated, as Josh mentioned in the introduction. So the first interest for me is in care team coordination, especially in critical care settings, how teams coordinate during rounds. The second interest in my research is in decision making, and this brings in all the cognitive aspects of decision making and thought processes and the methods from cognitive sciences. Medication ordering is another area of my interest, where I look at medication ordering errors and look at interception mechanisms used by clinicians during ordering practices. And lastly, handoffs and care transitions has been my passion in terms of my research areas, both within unit handoffs as well as also care transitions between settings. Although there are 4 different spaces here, or 4 broad areas, the underlying goal for all the research I do is to build safer systems for improving care outcomes. So now I'll move on to the topic that I'm supposed to be presenting, which is handoffs and lost art of communication. As you all know, handoffs involve a transfer of care between a sender, who's pretty much the outgoing clinician, and the receiver, who's the incoming clinician. And this transfer of care usually involves a transfer of information, responsibility, and control. Several researchers, including myself, have found that there are other functions in addition to transfer of information, such as shared cognition, which is where you transfer your thought processes during handoffs. It is a forum to support social interaction, where you actually have an opportunity to ask and respond to questions regarding the patient case. Stereotypical narratives, where you have the opportunity to highlight risks or deviations from the usual care for patients. And lastly, resilience, which is the idea, can you bring in a fresh eye perspective about the patient because you are more well rested and you're coming into taking care of the patient. So these are different collaborative functions that have been talked about with respect to handoffs. So the idea is that all these functions need to be achieved in order to maintain care continuity during handoffs. So despite its importance in care continuity, as you all know and are familiar with, medical errors are a leading contributor, or the 3rd leading cause for deaths in the United States, and of which communication errors have always been the 3rd leading cause, or it actually leads to 70% of errors in healthcare, and of which 35% of those errors are actually occurring during these handoffs or care transition points due to fumbled handoffs. There have been several examples or cases and anecdotal reports on what these failures could be. And these are a few examples where there is missing information or inaccuracies in information that's being transferred, and which has actually high-level impact or consequences on either medication errors or leading to in-hospital complications and unplanned changes to care. So what researchers, including myself, have done is we started off looking at retrospective methods like survey-based studies, where people actually do surveys nationally or within hospital to understand what these failures are. And you can see there are, if you just Google, you'll see there are over 100 studies just looking at using survey-based methods. At the same time, researchers started coming up with these reports that there is no good way to measure handoffs because there is no gold standard. All the surveys are useful to understand the perceptions of clinicians and how they feel about handoffs, including the barriers, but there is no actual way to evaluate what a good handoff would look like and what the failures are as a result of poor quality handoffs. So this is one study or one report that talks about how these standardized reliable tools are unavailable or are limited. Part of the reason is, like I mentioned, there is no gold standard for defining what an ideal handoff would look like. And the other reason is there is a lack of measures available for handoff evaluation as a result of not having a gold standard. So that's when I started my research in handoffs, and I decided to start off with more prospective evaluation where, given my background in human factors and observational studies, I started off, my first study was to look at what are handoffs and what is the process of handoffs and how can I contribute to the understanding and how can I come up with these good measures for handoffs. So this was a study that I started off with where we used more qualitative research methods such as shadowing. We actually shadowed the clinician for the entire shift and try to understand what they do. And we found that handoffs can be divided into phases. So there is actually a workflow or a process. So prior to handoff, a couple of hours prior to the handoff, residents and nurses actually spend time documenting and seeking information, which is referred to as the pre-turnover phase. And then you have the handoff communication phase where they actually communicate. And finally, a couple of hours after the handoff, they actually take responsibility and work on the immediate care coordination activities that are needed to achieve care continuity. So the other thing we were able to identify as part of this study is that the breakdowns that happen in the pre-turnover phase actually is directly mapped to the communication breakdowns that happen during handoffs. So we were able to do a one-on-one mapping as to what information is not being collected during the pre-transfer phase is actually related to the communication flow or the communication failure that happens in handoffs. So there are errors that can actually propagate across or among these different phases. So that was our first study. And then this was followed up with another study where we wanted to actually look at, okay, what are these breakdowns? Can we actually come up with ways to characterize these breakdowns so that we can actually define it and evaluate? And again, going back to the argument, then can we come up with better prospective ways of actually measuring handoff quality? So this was another study that we worked on, and we did this for both residents and nurses in the medical intensive care unit. And we came up with this framework as to, these are the 5 different failures that happen during handoffs, both within resident handoffs as well as nurses handoffs. So doubtful information is if there is any uncertainty in the information shared and people ask questions about that. Missing, as the name suggests, it's just not available during the handoffs. Incorrect information would be inaccuracies. Repetitive information is that there is redundancy in the information, that it actually leads to information gaps. And misinterpretation is there's a misunderstanding in the information that is being presented. So this was our first framework to actually evaluate handoff quality. And moving forward, we then looked at the tools that people have implemented to support handoffs. So as some of you may know, given all the handoff errors that are that happen with respect to the quality of communication, the Joint Commission actually put out a national patient safety goal. And the goal was that we need more standardized approach to handoff communication, and there should be an opportunity given to ask and respond to questions during handoffs. So to adhere to this goal, the hospitals in the United States actually went ahead and implemented number of standardized tools. Some were paper-based tools, some were more electronic standalone tools that are outside the system, and some were more EHR integrated tools. So we also did something similar to that at that time, where we developed a tool referred to as HANDIT, which is Handoff Intervention Tool. So this is something that we implemented in the medical intensive care unit. It's a paper-based tool, but the structure is basically, it follows a system-based or organ system structure. And within each organ system, you talk about the physical exam labs related to the organ system, the medications, the assessment, and the plan for the patient for that particular organ system. So this was the first tool that we implemented, and now it's actually integrated within the EHR back at University of Texas, Houston Hospital, which is Memorial Hermann. So that was the first tool. So we then evaluated the tool using a pilot prospective design, where we actually compared it to the SOAP tool that was available for the residents. And we found that this tool actually reduces the number of information gaps that we presented earlier, and also improves the decision-making that happens during handoffs. So it actually improves the care plan thought process, especially for interns, because they are new to this process, so it actually helps in reasoning. Followed by this, there were other mnemonics that were in place to standardize handoff communication. So these are a few examples from a systematic review on mnemonics. As you can see, there are many mnemonics to support both shift-based handoffs and communication between units. And IPASS is one of the mnemonics that has received a lot of attention, and it's basically standing for illness severity, patient summary, action list, situation awareness, and synthesis by receiver. So this is a mnemonic that is actually integrated within the Epic EHR system right now. So everybody who use an Epic system should be familiar with the IPASS mnemonic. So what we did was we used the IPASS mnemonic and extended it for nurses, because the IPASS was mainly developed for residents in pediatrics, and we thought it would be a good idea to actually use it for nurses rather than standardizing it across all disciplines. So my team and I, we worked on a study where we actually used a Delphi method with the experts all over the United States, and came up with a mnemonic for nurses, so which is referred to as NPASS, which is Patient Summary, Action Plan, and Synthesis. We also we then validated our mnemonic with real world handoffs, and we found that synthesis was one piece that nurses usually were never used to or did not use during their communication. They were more focused on the patient summary and the action plan. So now we are actually making some revisions to our mnemonic so that we can standardize it for nurse handoffs. So during this time, there were a lot of publications and perspectives on how these handoff standardization efforts are not achieving handoff quality, because it's actually, there was some mixed evidence on the good, bad, and ugly of standardization. Not everybody was actually using standardized protocols or standardized tools and mnemonics. So we then decided we will try to see if there is an impact on the standardized tool, and how much of it, how many residents actually use their tool in terms of during their communication. So we did a comparative assessment where we compared the tool, the document that they used, and what they were communicating during their verbal handoffs. And we found, and again, we do this manually at that time, so we found that there is a complete overlap or a full overlap in patient identifying information and tasks. So whatever is in the document is what they communicate with regards to patient identifying information and tasks. There was partial overlap when it came to active problems or assessment of active problems. So some of which was written in their document, and some of which they actually communicated. And again, with anticipatory guidance, it was the same result we found. And there was absolutely no overlap or limited overlap when it came to pending labs, medications, and code status and allergies, which is not surprising because not everybody has to talk about a code status if it's not relevant for the patient. So although it's written, it may not be communicated during handoff. So this was one of the studies we conducted to understand why people were, or what parts of the tool that they were using during their communication. So we did a systematic review during this time to see, okay, besides our studies, what have studies found in terms of these evaluation of handoff tools? Are people actually using it? What is the sustainability of these tools if it is standardized? So our results found that one, there's a rigid structure in standardization. People were not used to following the rigid structure. Although it did provide a checklist, they were not used to actually communicating using the same structure. Second, there was limited support provided by these tools and mnemonics for collaborative functions of handoffs. Like I mentioned in my first slide, there are other functions such as shared cognition, such as social interaction, stereotypical narratives, and resilience that were not actually supported by these handoff tools. The main function that was supported was mostly on information transfer. The second piece was there was a lack of support for disciplinary and interdisciplinary team workflows. So especially in the medical intensive care units, like you guys know, there's a big team-based approach to care. So there's not enough support for those care coordination or interdisciplinary functions. So as a result of which, there was limited sustainability of these tools and mnemonics in practice. So if you go to the field, this is what we found during the time when we were doing our observations. You'll see that people go back to their own problem list or their own tools that they use, that they carry around. Nurses use their own diaries that they're used to, and their own problem list or to-do list that residents come up with. And finally, there are these tools, they print it and then they write down notes on it. So there is no way to actually standardize handoff communication across these different handoffs. So we then started investigating into cases where people have found these standardized tools to be a failure. So we looked into the Joint Commission reports on medical errors and handoff errors, and this is one of the cases that came up there. So let's say a patient came with pain and swelling to the right calf after a sports injury. So the orthopedic surgeon suspects gastrocnemius tear, but fails to document it in the EHR. So the patient is then wheeled to the med-surg ICU. There's no formal handoff. The patient says it's a self-reported DVT. The radiologist then does the scan and notices a loss of flow, but fails to document it or follow up with the physician. And then there is a shift change that happens between the day nurse and the night nurse, but the day nurse does not talk about the CT scan. The night nurse, when she assumes care, she assumes that the scan results were already discussed either during resident handoffs and nurse handoffs. But in reality, nobody discusses those scan results, and there's a delay in the surgery, and the ICU nurse later on notices necrosis for the patient, and finally the patient ends up with the amputation. So this was one example of a case that was reported by the Joint Commission to show how these different breakdowns happen, not just between resident handoffs, but also between the entire team. So we thought our first step would be to then look at discipline-specific handoffs and see if we can leverage the similarities and differences between residents and nurse handoffs. So we went ahead to and started off to work on a conceptual framework as to how can we support both discipline-specific handoffs, but also support interdisciplinary communication and care coordination. So we started off with a study where we talk about how can we develop this framework or ontology of interdisciplinary handoff communication. So the basic idea, I don't want to get into the nitty-gritty details, but the basic idea is that can we leverage the similarities across communication between residents and the similarities across nurses, and also leverage the non-overlapping content or the dissimilarities between the two groups in some form that it would actually lead to improved conversations or conversational grounding, which then can lead to better outcomes. So we published this in Human Factors, and this was the next set of studies we worked on in terms of comparing resident handoffs for the same patients and nurse handoffs for the same patients. And this was basically the idea is that if you want to fix something or if you want to develop a tool, just automating the process wouldn't work. You actually need to understand what's going on in the process. And that's exactly how we started reviewing this, this research. So we conducted a series of studies and we looked at both resident and nurse handoffs for the same patients. So we had around 275 handoffs in general medicine unit. And the things that we were interested in was their conversational structure, the content, the flow of conversations, and finally their interactions. So for this study, we actually used audio recordings of their handoffs, and for analysis, we either used qualitative data analysis, which is basically you openly code the data, you follow a grounded theory approach from open coding all the way to thematic analysis. We also used something called sequential analysis, where we actually look at the sequence of conversations and then try to come up with patterns in the conversations. So first I will present my work on similarities and differences between resident and nurse conversational structures. So this was based on the qualitative data analysis that I talked to you about. So in this paper, what we found that was both residents and nurses, they used something called narratives, which is basically, they used a story kind of conversational strategy while they talked about their patient. So three narratives that stood out to us in this research was for creating clinical imagery, for coordinating their care continuity tasks, and integrating contextual aspects of care. So these were the three different narratives that stood out in both residents and nurse handoffs. So in terms of clinical imagery, residents always used patient condition or situation or encounter to introduce a patient. So when they started off their handoff, they say, okay, this is our liver patient, or this lady came to us from the ICU. So that was one way to introduce the patient. Nurses, on the other hand, always use the traditional format of presenting the patient, where they start off with the age and the name of the patient. So what it says is that residents used a top-down approach, which is similar to how they actually think and their thought processes. They start off with the diagnosis and then try to fill in the gaps or with the relevant information. So what we found was they start off with the clinical imagery of the patient, where they introduce the patient that this is a patient who came from the ICU, and then they talk about why the patient went to the ICU and how did they end up coming to the medicine unit. Nurses, on the other hand, they start off bottom up, where they actually fill one piece of the information and then they build it up to come up with a bigger picture. And this could be because of their roles and responsibilities in the medicine unit. Moving on to the coordination of care activities, we found that residents, again, this could be related to how their role in the patient care team, that they talked a lot about coordinating activities or tasks between providers who were outside and within the unit, and mainly providers like consuls who came into the unit, and what needed to be done in terms of their tasks to do. So there was a lot of emphasis on the task to do piece here. And the nurses, on the other hand, were also interested in tasks, and their narratives were focused on within unit tasks or about conversations between the patient and the providers. So they served as a liaison between patients and the providers. So that was one other thing that stood out, or analysis that stood out to us in terms of differences. Then we finally noticed some similarities also between resident and nurse narratives when it came to contextual aspects of care. So they both talked about patient demeanors. They both were talking about, okay, this is a laid back guy, and that immediately knew that, okay, there's not a lot of work with the patient. They both talked about problematic situations, like I mentioned, stereotypical narratives where you highlight the deviations in care or highlight the risks related to the patient. So they both emphasized the problems in patient care. Finally, they also talked about some uncommon or unusual situations where they talked about, okay, this patient came to the ER with 7 suitcases. That immediately raised a red flag. Okay, probably the patient is a homeless person, so that's why the patient is actually coming to the ER so many times. So there were certain things, although it's not directly relevant to patient care, they still provided enough context for them to understand how to take care of the patient. So there was a lot of similarity in how they communicated about the patient in terms of context. And these were pieces of information that we found was not actually documented anywhere. It was only as part of their conversations. And this is where we feel that the standardized approaches do not work to capture or do not help or support the capture of these kinds of information. Moving on to our next goal was to look at conversational content to understand, are there similarities and differences in the content itself? Like I said, based on our prior research and over 5 years of work, we adapted a framework that is already established from another researcher in terms of the content, and these were the different content elements that are available or that are actually communicated during handoffs. So first what we did was, in order to identify the overlap or the content similarities, we just couldn't do it manually. So we then used natural language processing techniques And we used an approach referred to as distributional semantics, where we calculate a semantic similarity score, which is basically a proxy for the overlap. So we validated a measure, and then we conducted a study where we could actually compare resident communication content to nurse communication content. And we found that the similarity was high, or overlap was high, for patient active problems and its assessment, past medical history, and medications and treatments. So there was a high overlap or exact match between the residents and nurses about these four elements. We found a low overlap, or there's pretty much residents did not talk about allergies, code status, family, anticipatory guidance, and pending tasks, and nurses had a partial overlap compared to the residents. So what it says is that there are this shared content that can be leveraged across the disciplines, and then there are these content elements that are unique to particular disciplines depending on their role. So the last but one element that we were interested in was conversational flow. Typically what the standard way we follow in terms of understanding conversations, or the proportion of the conversation, is to use a bar graph to say, to count the frequencies or get counts of, okay, how many tasks did they talk about in the conversation, and compare it between residents and nurses. This is extremely useful when you want to look at topical importance, but it's not useful to understand the flow of conversations. So what are the switches between conversations? After I talked about past medical history, do I talk about medications and treatments, or what is the way in terms of the conversation, like how does it flow? So what we did was we then used an alternate approach, which is referred to as graph-based networks. We used that particular approach to understand the flow of conversations. So what it basically does is, if you look at this picture here, it's a conversational network, and the nodes here represent the topic or the element that they're talking about, and the transitions, or one node to the other, is basically how they switch between topics. So there are standard measures in graph theory or graph-based method that we actually used for our study also. So just to give you like a 101 on it, it's the general measures are nodes and edges, which is basically what I talked about, which talks about the conversational topics and the transitions between topics. Then you have something called connectivity measures, which is what are the core topics? What are the topics that are highly connected between each other? Then recurrent measures, which are more related to frequently approached topics, or the loops that go between topics and the topic switching. Finally, global measures, which is the diameter, the density of the network, which gives you a general graph size and whether your network is actually stable or not. So just to put it in perspective, we actually did that for residents and nurses. We compared their conversational networks. So as the graph here shows, nurses actually had fewer nodes, which means they had fewer topics to talk about, but they had more edges, which means they went back and forth between topics, but they had only fewer topics compared to residents. As far as the parallel edges go, you can see that they repeated the topic. So they went back and forth, but they had more branching, but they went back and forth between the same topics. As far as the general density and diameter and average shortest path, you'll see that nurses had fewer, or the diameter was comparatively smaller compared to the residents, which means although they went back and forth between topics, they did not have a particular order in their presentation. So it was, although it's highly focused and detailed, they didn't have a particular order in how they were talking about these topics. On the other hand, the residents had a particular potential, and we are guessing that they had an order in their presentations between the topics. So if you go to the next slide, we actually show what these topics mean. So if you look at active problems, disposition, family, medications, other past medical history and pending labs, and tasks to do, you'll see that there were similarities between residents and nurses in their networks. So let me just get you an example for active problems. You'll see after active problems, they went both residents and nurses talked about assessment of active problems right after talking about active problems. So there is some potential, which basically suggests that there is some order in how they're presenting their topics. We noticed differences between residents and nurses in their presentation of anticipatory guidance, assessment of active problems, and identifying information. So if just looking at an example for identifying information, so residents, as you can see, will always talk about identifying information and then go to active problems and past medical history. Whereas nurses would talk about identifying information and then go to active problems of the patient. And this relates, or this can explain some of the things I talked earlier about narratives, about their clinical imagery. So here you can see that residents would talk about the patient identifying information as, okay, this is a gunshot wounded patient, and then talk about the active problem, versus the nurses, on the other hand, would talk about the patient identifying information and then get into the presentation of the problems of the patient. So, so that was another thing we did with respect to understanding conversational flows and understanding the differences between the two groups. Finally, we looked at conversational interactions. The reason we looked at interactions is, as the Joint Commission mentioned, there should be a standardized approach and there should be an opportunity to ask and respond to questions. So we thought it would be a good idea to see if there were similarities and differences between residents and nurses in their interactions during these handoffs. So we first started off with listening behaviors. This is basically a framework that is used to code listening in handoffs. So active listening is whether they read back or synthesize back the information, and passive listening is, okay, they say, okay, so those is more passive listening formats. So we compared both residents and nurses in their listening, and we found overall there was limited listening, and even when we actually coded these listening behaviors, we found it was mostly passive in nature. Same way we did questioning, questions asked during handoffs. This is another framework that's used to code these questions in handoff literature. So we borrowed the framework to understand whether the questions were related to reasoning, coordination and planning, framing and alignment, and patient status. Similar to listening, we found there was overall limited questions asked during these handoffs. And most of the questions, or over 50% of the questions, were related to patient status. So it was not much related. We did not find significant associations with the other types of questions. The other thing we found that was the number of questions asked by nurses were actually more than the number of questions that were asked by residents, and it was an increase in 76% in the number of questions. We also looked at a hypothesis. We wanted to see whether listening had any relationship with the questioning. So the more you listen, the more questions you're able to ask. So basically, we did a Poisson regression and found that a unit increase in their listening behaviors actually increased the number of questions residents asked by 7%, and the questions that were asked by nurses by 12%. So which basically says that you need to engage people, or you need to engage our participants in active listening and questioning behaviors. Finally, I want to, based on all the work that we have done over the last few years, we decided that we have to come up with some design implications for handoff tools. And the idea is that we need more collaborative tools, and we need to or adapt our standardized tool to make it more flexible and support both disciplinary and interdisciplinary work, given these similarities and differences that we can leverage upon. So our first design requirement or goal is to find ways to standardize the shared information, because as I presented earlier, there's a lot of information that they had an overlap among residents and nurses. So the goal is to standardize that shared information, but then support flexibility in the unique content, like contextual aspects of care, or anything related to anticipatory guidance, contingency planning. So then we can actually spend most of our time in the unique content and not the standardized information that's easy to find. So the idea is to then support information seeking and documentation such that it actually supports their reasoning. So for residents, it would be a top-down approach, and since they follow a top-down narrative strategy, and for nurses, the unique content should be focused on a bottom-up approach. And we have to have varying structures in their documentation, and also support internal and external task coordination, because both for nurses and residents, the to-do list was an important aspect in their handoff conversations. The other thing that we noticed, like I mentioned in our contextual aspects of care or contextual narratives, is we need to have tools that can support that via documentation, so it is documented and not lost in the verbal communication. So we came up with this idea: can we have something at the back end which is like the handoff metadata? So it's not part of the formal record, but it's still there so that people can actually read and get more understanding about the patient. There is a lack of active listening that happens in handoffs. So one way to get people to actively listen and engage in the conversation would be to get them to tag the important content while they're doing the handoffs. The last requirement in terms of these interdisciplinary communication and disciplinary communication, we had this idea: where can we develop these shared displays or shared information spaces where people are looking at the same information while they're communicating, and we can actually spend more time on those risks or deviations to care, rather than narrating the entire piece of information on our tools. So the idea is, can we come up with these shared information interactive spaces to support care coordination and grounding and communication. So towards this goal, we started developing a shared space, and this gives you an example of our shared space using a SAGE environment, which is a large multi-scale display, where we first talk about all the patients in the unit and their risks to care, and their based on their severity, their Apache scores, and then hone it down to a particular patient. The idea is that we can make it more collaborative and interactive, and also support all the other functions that I mentioned. So not only information transfer, responsibility, and control, but also support shared cognition, interaction, stereotypical narratives, and resilience. With that, I'll move on. I'm towards the end of my presentation, so I'll move on to what I'm doing right now at WashU. I'm new to WashU. It's been over a year since I moved to WashU, and since I'm in the Department of Anesthesiology and part of medicine, my current research is more focused on perioperative handoffs, so both within OR, which is intraoperative handoffs. There's a lot of work on how intraoperative handoffs actually increase the risk for mortality and adverse events, so I'm very much interested in intraoperative handoffs. And I'm also looking into postoperative handoffs, that is OR to ICU or OR to PACU. And the goal is to use telemedicine, or we have something called an anesthesiology control tower. So we're looking at how the anesthesiology control tower, which is basically like a EOR, a telemedicine to the OR, can support handoff communication and the different functions. In addition to that, I'm also working on critical care handoffs, because that's where I started my research in handoffs. So I'm doing a study on ED to ICU handoffs, where we look at team handoffs and how we can improve the efficiency in the process. ICU to ward is another handoff that has been vulnerable to errors. And the last one, which I'm working with Dr. Denson, is end of service or rotations handoffs, where we are looking at whether patients exposed to a care transitions at the end of, or patients exposed to end of service transition actually have higher mortality rates or not, which is a multi-site study, which I'm super excited about. So like I said, the goal of all these, my most recent work has been on patient risks and identifying strategies to support risk-based communication rather than standardized communication, and also to leverage the role of telemedicine in supporting handoffs and the different aspects of handoffs. With that, I would like to acknowledge all the funding agencies. I've been very fortunate to get funding from different agencies that focus on patient safety, health IT, and also NSF, which is mostly focused on the my technical aspects in terms of machine learning and natural language processing. So that's been really helpful to support my research. The study participants and my key collaborators who I continue to work, although I've moved between institutions, and my students and postdocs who have helped me work on the data collection. With that, I think I'm happy to take any questions, and I think there are 15 minutes for questions. Thank you all for listening.
Thank you very much, Dr. Abraham. That was awesome. I think we do have a few minutes for questions. Unless Dr. Bottoman interjects, I'll kind of moderate this session. If anyone has any questions, please put them in the chat box, and I can kind of try to moderate. I had a couple questions that I was interested in myself, of course. There were two areas that I was curious to ask about. One was, you were talking a lot about the contextual aspects of care, and that this is a laid back guy, or, you know, and you know, I'm in the ICU today in dealing with the same kind of handoffs and discussions. And it came to my realization is a lot of the handoff tools so far that are in practice, they are structured from a patient care perspective, right? This guy is this old, here's his medical problem, here's what we're doing. But I can't actually think of any that really take into effect these contextual aspects of care and the social construct that these patients go into. You know, DNR or code status is one area, but that's such I feel like a small part of really what is needed, because anyone on here that's a clinician knows that they talk about something to remember the patient by, and that, to me at least, jogs my memory for the medical illnesses. And so my question going from that is, what ideas have you heard of, or are you aware of, or have you thought about working or waiting to implement this into a tool or intervention system?
Yeah, so that's a good question. So the first idea was to use these post-its within the system, where you actually can tag and you can actually write something about the patient that is not part of the record, so people can actually read it and find it useful. Usually these pieces of information are shared only during verbal communication, and it gets lost. So if you don't have time for a handoff, or you are actually not present at the handoff, you lose some of those contextual pieces. So in terms of design, so the first thing was, like I said, the idea is to use what we already have within Epic, because it's very difficult to implement this within the EHR or come up with a new button to talk about these contextual pieces. Some people may not even be, what we found is not a lot of people are comfortable writing it in within the system, because they feel that it will backtrack, or it will be linked to them. So it's not, you can't tell that, okay, this is a difficult patient and write it somewhere within Epic. So the idea that we had was just come up with this metadata somewhere that it lives, so people can actually use it, or think about use it as to prime questions, or to manage the patient better. So yeah, there is no answer to that in terms of how do we get it documented in these tools. Right.
Yeah. It just I guess brought to mind a big gap in the processes that are understanding right now. So there's one question. Yeah, Dr. Zafoja asked, how do you streamline handoffs and make it so that they aren't the final hurdle before being able to go home after a long day, right? Because they take a lot of work. I mean, we all know they take a lot of work before the handoff, as you mentioned, during the handoff, and then after. You know, if you forgot something, oh, I should have told them this. You know, how do you streamline that?
So that's a really good question in terms of streamlining, and I think that's based on all the work that I have done in terms of actually talking to clinicians. It is a lot of work if you keep it to the last minute to just prepare this handoff document. So the idea is, can we actually integrate something within their current tools rather than developing a new handoff tool just for handoffs. But that's where I said that there should be a way to develop care continuity tools that support just care in general. And handoffs can be more specific to these functions of, okay, what should I tell the next person that is absolutely important for the person to know? Those risks and thought processes about why they did something and what should not be done, anticipatory management, and keep all the rest of the information in this general space or general tool or EHR. So one strategy that we have started looking into is using rounds tool that is already there. How can we just pull the information from the rounding tool into a smaller handoff space or smaller handoff sheet or whatever it is, rather than getting residents and nurses to start filling in a new form? So how can we auto-populate or reduce the amount of work that happens in the pre-turnover phase? So that is something that I've been working on, but it's not that easy.
Right. You know, I think that's one of the things that you know, everyone wants this to be a more streamlined, and everyone is just making it up at wherever they are, whatever they're doing, you know, following the tools and protocols. But I was going to ask another question about something else you asked, but I kind of skipping that. I was going to ask a little bit about the top-down and bottom-down approach that you discussed between residents and nurses, and they're very different, it sounds like, in a lot of respects. Is there a way of putting these together to, again, improve the efficiency so that it's not a task that we're all waiting to do and be done with, to make it part of the daily workflow, and to get buy-in that these hospitals should come together? Yeah.
And I think the top-down, bottom-up approach is something that they're trained on, residents and physicians in general. If you look at the knowledge hierarchy, like the epistemological framework, you'll see that they always, it starts from the diagnosis and then goes down in terms of to reduce the amount of biases and all that kind of stuff. So, so it's natural for them to think like that. And our goal is to develop something that allows them to think and not just use it as a pure information transfer forum, but also think about it and catch the errors that happen during handoffs. So, so that's another big project. And there are many questions. I guess the goal, what I want to say is there are more questions than solutions, and more problems that we need to work on.
Right. I think Dr. Simon has a question, if we can get him unmuted. Are you there, Dr. Simon? Seems to still be muted. See here. James, are you able to unmute him, or?
I'm seeing if I can. So who am I looking for?
Dr. Simon, Eric Simon.
There you go.
I didn't ask a question.
Oh, sorry. Sorry, I was told that you had a question. The last thing I have, since we do have some minutes, was the last part you mentioned about the OR anesthesia tower. In a sense, it's like a kind of a air traffic control, maybe, for the OR. Could you just kind of it sounds pretty cool.
It is. It's the first in the country, and that's what that's why it's super exciting for researchers like me to leverage that resource. So it's an anesthesiology control tower. The basic idea is that they watch over the OR activities, and they can actually, so we have 48 ORs in our hospital, so they can actually zoom in and look at the activities that happen within the different ORs. Their role is to provide guidance for the clinicians, mainly the anesthesiologist, in terms of risks that they see is going on for the patient. So they do get all the vital signs and things, so they watch out for that. So they are an extra set of eyes for the clinicians in the OR, and they send a note. They actually call them and also send a note as to ways to mitigate those risks. So they provide some guidance, and those guidance that they provide is based on literature. So they do send information as the surgery is happening to the clinicians as to what needs to be done. I'm seeing something going on here. Probably some vital sign is deteriorating, so probably you want to do this. So those are the kinds of guidance that they do provide. So they work with a company called Alert Watch, which is the decision support software, which provides these alerts for them to tackle. So the idea for handoffs is like, how can we use them, because they are a big participant in these OR intraoperative care. How can we use them as a participant during OR to ICU handoffs? Because they do have this information. And sometimes what we notice is that not every time that all the members of the OR team actually come to the ICU. So basically we want to use the anesthesiology control tower as our liaison for providing or filling the gaps in those transitions.
Right, so it'd be kind of like a second,
yeah.
A second set of ears, a second set of eyes. And it sounds like they're already invested in that for the OR running in general to maximize safety.
Yes, yes, and that's the idea. Can they, because again, they're not at the bedside, so probably they are seeing things that are different, and of course they have more time to them to research the patient and look into it. So we have it completely staffed with an attending and residents and CRNAs who can actually build, can be a good safety net for handoffs. So that's pretty much what I'm trying to investigate. Can I use them for bringing the fresh eye perspective and other functions that we mentioned, that I talked about?
Dr. Abraham, I have a quick question. First, I want to thank you for this very interesting presentation. Clearly, the informatics had the potential to provide us with tools which is likely to make tremendous impact on patient safety. Is this kind of thing making to medical school curriculum? Do you know examples, plans on this?
So no, we haven't at WashU or at in the School of Medicine here. We don't have any training related to handoffs that have been like formally given. I do present at different venues so that people are aware of the handoff issues. But at my prior institution, I was part of this handoff training task force where we did use it as a capstone project at the end of their medical students training. So the last 1 week was on just interprofessional communication skills. And one of the communication topics were on handoffs, where we did some handoff simulations and used our medical students to go over different tools, not just IPASS, but go over SBAR, SOAP, the handoff intervention tool that I developed. So they try to simulate the different handoffs, and we have something called NEAR, which is like a educational EHR system where we can actually integrate these cases and get them to, we put them in groups of 3. So you have a handoff sender, a receiver, and an observer. So the observer will evaluate the quality, and then we do like a debriefing at the end to see which tool works. It was clear from all my experiences with that there is no one tool that works. It really depends on patients. It really depends on the context, your situation, how busy you are, and things like that. So that's how I guess I've driven my research in terms of, I'm not trying to develop the best tool, but I'm trying to highlight the important pieces that cannot be missed during handoffs, and all the other pieces you can find it yourself in the EHR system. So, does that answer your question, Dr. Badman?
Yes, thank you.
Thank you.
I think we're almost at the end of time. Maybe we can close. I want to thank Dr. Abraham for this wonderful presentation, and Dr. Denson for moderating and introducing the speaker and giving us the opportunity to get to know her work a little bit. And we appreciate everybody else joining in on the grand rounds, and wish everybody a wonderful afternoon. Thank you all for joining.
Thank you so much for having me. Thank you. Thank
Thank
you, everybody.
Bye, everyone.
Thanks. Take care.